Okay, so first and foremost, I want to thank one of my mentors, Jeff Ponsky, for allowing me to give this talk on the spleen. It's if you look back in the past, I never thought I'd be talking much about this organ, but it's one that I've had a lot of experience with in the past. And this picture right here actually shows you the largest spleen that I've ever seen in my career. It was almost 15 pounds. And the interesting thing about this man is that he wasn't concerned about the fact that he felt very tired because he was profoundly anemic. He wasn't concerned that he lost 60 pounds because he felt he was always full, but rather he just couldn't get over the fact that he always had the urge to urinate. And this spleen was so large it was pushing on his bladder. And this is kind of my introduction to the spleen. Now, I always find that when I give a talk to anybody, it's always interesting to look intellectual. And this is a picture from Frederick Edwin Church. It's Twilight in the Wilderness. And when I was in college, I took an art history class, and I had to write about this painting. And in the end, this actually is in Cleveland, and I still look at it all the time. And what this shows is from 1860, before the Civil War, and these were the clouds and the fire of war coming on. And then the way out there in the future is peace and sunshine. And hopefully, I'm going to throw in the next hour, I'm going to throw a lot of information at you. But hopefully, when we're done, we'll see that nice shining sun in the background and they feel like it's been worth your time. You always have to start off with a historical background. And I can tell you, I've actually done splenectomies on a bunch of Greek people. And indeed, the spleen, the word for spleen is splen. Could also cover the word splankton, which is viscous, or spa, which also means draw because of the dark purple color. So thousands of years ago, Hippocrates felt that the spleen was a source of black bile. There were four cardinal humors: the yellow bile, the black bile, blood, and phlegm, and this was felt to be related to melancholy. Plato took this further and felt that the spleen was actually used to cleanse the liver. Though there are reports from the ancient Greeks that people could run faster without their spleen, and Greek runners were burned in the left upper quadrant with a hot poker, reportedly. Interestingly enough, in like the early 1920s, they did do a study, and they felt that splenectomized mice may run faster than those who did have their spleen, but that really wasn't proven. Galen felt that the spleen discharged secretions into the stomach via the short gastrics, and this was again crucial for internal balance. So you're seeing a progression in what the spleen really did. Vesalius, in his book, felt that the spleen draws itself into the refuse of the liver and converts it into nourishment for itself. And what it cannot assimilate, what it cannot take care of, it then throws up into the stomach. Go back further, we can say the Talmud. Now, you said that the spleen was it was felt that the spleen was a seat of laughter. And so if you removed it, people would lose their capacity to mirth. And William Harvey in the 1600s said the spleen causes one to laugh. So for a long time, there were a lot of questions as to what the spleen really did. And you go back between the years, 3,000 years ago to maybe a few hundred years ago, there were a lot of theories. When you get to the 19th century, you start seeing some more of these historical milestones. The first reported splenectomy, this hasn't necessarily it's been reported and not documented. A rapist was reportedly stabbed in the left flank by his victim, and the spleen herniated through the wound. In 1926, the first documented splenectomy was performed by Dr. Quitterbaum in Germany. This was performed for hypersplenism due to cirrhosis, and not surprisingly, the patient died within a matter of hours. The first splenectomy under general anesthesia was performed by Dr. Wells, and the patient did not survive as well. So, 1865, the first documented successful splenectomy was performed by Dr. Payen in France, and a presumed ovarian cyst actually was a huge splenic cyst. 1892, the first trauma splenectomy was performed by Reigner in Germany. So what you have right here is you have a lot of case reports. So you've made a lot of movements in understanding the spleen, and this takes you really to the point where there's still a question how important the spleen is, and the spleen is no longer a member of the non-essential organ support group. Because in the 20th century, you start seeing some very important historical milestones. McKelly determines the spleen is the site of red blood cell destruction in autoimmune hemolytic anemia. Now, to make me feel even more inferior than I am, Kasnelson, who was a medical student in Czechoslovakia, postulate that the splenectomy would actually potentially cure ITP. 1929, they noticed several members of family who underwent a splenectomy for autoimmune hemolytic anemia died. And this kind of put a damper on performing splenectomy for people which they felt did have hemolytic anemia, although they weren't sure why it had happened. 1937, Dr. Dinsmore observed that the thin capsule, the ligamented attachments, increased the potential for trauma from the spleen, and more importantly, that the surgeon fingers could pop through it. And this is the feeling I get every time I'm doing a case like this with my residents. In 1962, the first splenic salvage procedure for trauma was performed by Dr. Cristo in Brazil. 1991, the first splenectomy by Dr. Delettre and Dr. Meignen in France. And the lateral approach, laparoscopic splenectomy, which I think right now is probably the most common approach, and it's clearly the one that I always use, by Doctors Park, Gagne, and Pomp. So you can see that the spleen has really gone from kind of a theoretical organ to one that really we realize the true importance of the spleen. The most important moment for the spleen, I think, in the 20th century was March of 1993. And if anyone is old enough, my residents don't really realize this as much as I do. That's the Junior Min episode of Seinfeld. And the patient actually was undergoing a splenectomy. You got to talk about some anatomy, obviously. The normal size about 13 by 7 by 4 centimeters. This is interesting because I get a lot of referrals for splenectomy in patients who are told they have splenomegaly when in reality the ultrasound may say that it's 14 or 15 centimeters. Typical weight 150 to 200 grams. Some people say it's got to be 300 to 400 grams to be palpable. I think it's probably got to be larger than that, but it may depend on the patient's body habitus and how narrow their costal margin is. Massive splenomegaly is felt to be 1,500 grams, although splenomegaly is diagnosed at 1 gram. I've seen people say 500 grams, but I really think that for this talk, I will consider splenomegaly to be 1 kilogram. Spans the 9th through 11th ribs along the middle of the posterior axillary line. It is the most vascular organ of the body, containing 1 unit of blood at any given time. And I can tell you that I once stapled across the hilum with a resident, and for whatever reason, the staplers didn't fire, but the blade did. And if you ever want to hear, I'd always heard about people talking about audible bleeding, and I can tell you that's exactly what happened when the staplers did not fire. Have to give credit to Dr. Netter, obviously. The diaphragm is superior. The ventral surface abuts the greater curvature of the stomach and the pancreas. And the tail of the pancreas touches the spleen in 30% of patients. And this is important when firing across your hilum. The inferior pole relates to the left kidney posteriorly and Gerota's fascia, and the splenic flexure anteriorly. Now, looking at the arterial supply, about 85% of the time the splenic artery comes off the celiac trunk. Now, there are two patterns of branching, because you can see you have these segmental branches, the concentrated pattern where the arteries divide close, and the distributed pattern where they branch further away. There's a superior polar artery, and then the short gastric vessels via the left gastric artery, and the spleen oftentimes can survive on simply the short gastric vessels. Looking at the venous return, obviously the splenic vein. It's to be associated with the posterior surface of the pancreas, and the splenic vein, as most of you know, meets with the IMV and the SMV to become and joins to become the portal vein. And there's obviously the left gastroploic vein for return as well. There are 3 ligaments which are always present. I put in the case of wandering spleen, which is something I've heard about and has shown up on tests and in papers, but something that I've really never seen before. The splenogastric ligament, which is the extension of the omentum along the greater curve, and this is where you will find the short gastric vessels. The splenorenal ligament attaches the spleen to the posterior lateral border down to Gerota's fascia. This will contain the splenic vessels and the tail of the pancreas, and the splenocholic, which is the inferior pole, is connected to the splenic flexure of the colon, and that does come important with dissecting up into the left upper quadrant. There are 2 ligaments which are variably present. The splenophrenic particularly, I can tell you that for the most part, people may have some flimsy splenophrenic attachments, which are attachments obviously between the spleen and the diaphragm. But I find that people who have had prior hematologic abnormalities. Maybe they had massive splenomegaly, which is treated with chemotherapy, lymphomas. They can have significant attachments to the diaphragm. And just 2 weeks ago, a man had a huge left upper quadrant mass, which was lymphoma, and it took hours just to free these attachments up from the diaphragm. They may say, "Why don't I just convert to open?" That's probably the hardest part, is getting up to the diaphragm. So you have to be aware of this when you are seeing these patients pre-op, and the splenomental attachments, which are more extensive lower pole, and this usually often can lead to capsular tails with traction, and this is where you see the colonoscopy injuries. And in my career, it's only happened once where somebody actually had a splenic laceration associated with colonoscopy. This is something which is increased with people on steroids. I think there's more in men, obviously, have more visceral fat, and with increasing weight. So this can kind of be bothersome when you're doing your dissection down there. Look at the splenic anatomy under the microscope. The capsule, as noted previously, is very thin, and it's very easy to put your fingers through this capsule inadvertently. It's just several layers thick. This is also why it's pretty easy to morcellate the spleen, which we'll talk about. The trabeculi really constitute the framework of the organ, and you can see this with the red arrows. Now, looking at the kind of the general splenic anatomy, obviously the capsule again is with the black arrows. The red pulp, which is about 3/4 of the parenchyma and is the blood filtering component, that is the red arrows. The white pulp are the blue arrows, and this is composed of lymphocytes. So this is essentially the same as tissue within a lymph node, and this is why I will say to patients, the spleen in some ways is just a big lymph node. So remember, where there's red tint, it's red pulp. Where it's dark, it's white pulp. It's amazing what you can find on Google. The Awkward Yeti likes to write a lot of cartoons about the spleen, and you can see they all make fun of him and say, "Shouldn't you be filtering old blood or something?" And indeed, hematologic function is one of the main functions of the spleen. The spleen is an interesting organ. That's a lymphatic organ which is connected to systemic circulation and not really the lymphatic ducts. So the primary role hematologically is the removal of old red cells, as well as platelets and white cells, as we'll get into. So the erythrocyte lifespan is about 120 days, and 100 billion erythrocytes are destroyed daily. It does have a minor role in hematopoiesis and storage of red cells, especially platelets. So if people have an enlarged spleen, it's really not that uncommon for them to have some element of thrombocytopenia. The other issue I did not mention is removal of erythrocytes who have deformities, as we'll talk about, for example, with serocytosis. Now, we're not sure. There are a couple of hypotheses which you can see right here is why are these red cells, how are they marked for destruction at 120 days? Is it a loss of membranous elements, so they become less compliant, as we talked about? Is the exposure specific surface markers? We just aren't sure. But that's ongoing. Now, we also know that the spleen can destroy platelets and leukocytes as well, and you can see all this confusing stuff, which I don't remember from med school, about interaction between FC portions of the immunoglobulins and phagocytosis. For the sake of discussion here, we will talk about hypersplenism, which is due to increased splenic mass. So you can see patients with hypersplenism, which in the situation when you're dealing about platelets and leukocytes, oftentimes we're talking about an enlarged spleen, which you have some element of decreased pancytopenia, and we'll talk about that as well. This may be due to the increased red pulp volume. Now, again, this is the Awkward Yeti, who I would like to give more credit to for writing many cartoons about the spleen. I am not beloved. I don't need to be. I filter old blood. I fight bacteria. I am a silent protector. I am spleen. He's wearing his little Karate Kid headband right there. And you can talk about the immunologic function of the spleen, which is kind of the second most important. Not in order, but it's just the two main things you think about when you think about the spleen. Filtration, trapping of circulatory antigens, and you can see that all of the necessary cells are present for immune response. Phagocytic cells, dendritic cells, T cells, B cells, proliferation, germinal follicles, and a lot of this will actually occur in the marginal zone, and that's where you will see. We'll talk about splenic marginal zone lymphoma, for example. This is a picture of the white pulp, and it really just looks like a lymph node. The central artery is surrounded by the PALs, the peritoneal lymphatic sheath with many T cells, and the B cell follicles, which expand with stimulation, and then the marginal zone, which we talked about, which has the lymphatics and the macrophages. Something that always shows up on tests when I was in med school and as a resident is the synthesis of opsonins, which are used to the encapsulate organisms for phagocytosis. There's tufsin and there's piperidin, and you can see there's different ways how they work. The thought is that the deficiency is somewhat contributed to overwhelming post-splenectomy infection, but the spleen is not the only source of these two opsonins. But this is why, for example, we'll talk about why you will end up giving specific preoperative immunizations. Now, we talked about people couldn't laugh if they didn't have a spleen and all this, but this is from the dictionary: to vent one's spleen, to openly express pent-up anger, often at an unrelated matter or person. And I think it's a pretty funny thing when I look at this, and it took me a while to realize that this is actually the spleen, which is venting himself. Like you've never vented your spleen. There are plenty of cartoons about venting spleen on the internet as well. So we're going to first talk about hypersplenism, and from the standpoint of a very general topic. It's an increase in splenic function manifest by a decrease in one or more blood elements. So anemia, neutropenia, and or thrombocytopenia. When you have all three of them, it's usually the spleen is kind of an overdrive, and you usually have an enlarged spleen. But you can also have hypersplenism as a generic term for an increase in any of these blood cells with a normal compensatory response. So you have low platelets, you have increased megakaryocytes, for example. And this correction, there's a very good chance that splenectomy will be helpful, and you won't necessarily have to have splenomegaly. And I would think that hypersplenism with and without splenomegaly are two completely different issues. So if you look at hypersplenism, and these are primary diseases of the blood cells. So there's a lot of lists of things that you can see right here. In reality, there's the congenital diseases, of which the classic one really is spherocytosis. When I look at anything through that list, I have done several splenectomies for sickle cell disease for people who just their crises were becoming more frequent, and for my N of only two, it has made somewhat of a difference. Now, looking at the acquired hypersplenism, there are more of the ones that we think about typically. There's hemolytic anemia, ITP, TTP, and I put Felty syndrome in there mainly because it's the one which is associated with neutropenia. So let's start with the hypersplenism as the source of anemia. And again, you can divide this up into intercorpuscular, which are really within the blood cell themselves. And again, the classic is spherocytosis, or extracorpuscular, which means is the antibody-mediated hemolytic anemia, warm, obviously, and we'll talk about that. In this list, you can see TTP, and the other ones, I think, are really not what we're going to deal with much when we're talking about splenectomy. So once you figure out hemolysis is occurring, what are the two most important tests? Obviously, peripheral smear is going to rule out many of these other. They're going to rule out many of these rule out or rule in many of these diagnoses. But really, it's the Coombs test. So the Coombs test is only positive in antibody-mediated hemolysis. And as I do more and more spleens, I really see how the hematologist will work up these patients. And these are really the first two things that they literally look at. So some things will never change. I will talk about spherocytosis. I've not done a ton of splenectomies for these people, but this is one of the classic intercorpuscular hemolysis, intercorpuscular hypersplenism cases. It's autosomal dominant. Obviously, again, this shows up on tests if you're a student or a resident. Spectrum or ankyrin, which alter the binding of the cytoskeleton, so they look like spheres. And if you look again, you can go on the internet and you can find pictures like this. And so you really have it's difficult for the red cells to make their way through the spleen, and they are destroyed. You can look at peripheral smear, Coombs test negative. Really, family history is actually probably the most important, and it's not uncommon. Several of the splenectomies I've done for spherocytosis, they've actually a parent or a sibling have undergone splenectomy as well. There's a clinical triad of anemia, splenomegaly, and jaundice, although it's not usually significant splenomegaly, and the jaundice is not as obvious as well. Because of the breakdown of the hemoglobin, you have an increased risk of pigment and gallstones. The treatment is always splenectomy. It's essentially curative, um, but timing is important. I'm not a pediatric surgeon, but they try to hold off as long as they can before taking the spleen out. It's not going to take care of the cause, it's going to take care of the effect. And also the consideration is whether to do a cholecystectomy. And of the few hereditary spherocytosis patients who I've seen in the past, actually several of them were referred to me for both procedures because the gallstones were symptomatic, and so the hematologist would say, "Okay, since you're going to take out the gallbladder, let's take out the spleen as well." It's nice to do it under one anesthetic, but it's not as simple, mainly because you're going to be on your side for one of them. So oftentimes I'll do the lap spleen, and then I'll kind of flatten them out, and I'll do the laparoscopic cholecystectomy. But usually both of them are done at the same time. But I guess that's you have to look at each patient differently. So let's move on to things which are more common, I think, which is autoimmune hemolytic anemia. And if you look at this list right here, you can see they can have anemia, jaundice, and possible fever. But in reality, there are a lot of reasons why it can happen. So idiopathic is about 50%, but the other 50% you have to rule things out. It could be infectious, it could be drugs, it could be neoplastic. When I look back at my database of splenectomies, it's funny how many people were ultimately sent to me for hemolytic anemia when in the end it turns out that it could have been lymphoma of the spleen. Cold and warm antibodies. The cold antibodies are IgM mediated, which I don't expect anyone to remember because I forget it every time. But the important thing is splenectomy is ineffective. If I've never done a splenectomy for cold agglutinin hemolytic anemia, whereas with warm antibodies, it's IgG mediated, but the treatment is splenectomy. Um, when you look at cold versus warm, I started off with the far side, and when I was in college, we had to look at these, and the one on the left is always my favorite. Hey, I love these things crunchy on the outside, chewy center. So I found the far side on the right talking about leaving the jungle, and they looked into something that doesn't even look like a spleen. Um, but there's cold versus warm, and there's always a point where you want to try to put a funny cartoon in there, and I just love the one on the left. So cold agglutinin, the treatment usually is immunosuppressive with chemotherapy. Plasma exchange is cumbersome, and most people don't do that. And then the splenectomy is not going to be effective. That's the reason when I've been referred to so many patients for splenectomy in my career, I've never received one with cold agglutinin. Now, the treatment of autoimmune hemolytic anemia warm disease is different, and it's supportive from the standpoint is, transfusion if necessary, rule out other etiologies. The first step, just like in some of the others, like ITP, is high dose steroids. A lot of these patients, three quarters, maybe even higher, will respond. But as you start weaning the prednisone, uh, only 25% will have a remission rate, and that's more of a 25% of the 75%. There are other non-operative medical treatments such as IVIG, which will decrease antibody formation, or rituximab, which is immune system suppression. Um, the one thing that I did learn um, from someone, Alan Lichten, has really been a mentor to me. He's a hematologist at Cleveland Clinic, and he said to me, "There's been a big change in that the presumption is the risks of surgery are lower than the risk of keeping people on steroids and some of these suppressive medications." So, if you can't tolerate the steroid therapy, so let's say the patient's, and so in addition to what Dr. Lichten had said to me, you also think about patients who they may be obese, they may have diabetes, and they just can't tolerate the steroids. These are the people who are referred to splenectomy. But in reality, I think we're seeing a big change over the past decade. It's about 80% successful. So that's even higher than an ITP, and it removes the site of destruction. And this is a paper from 2010, which really was one of the first times that I saw Dr. Lechner is actually he's a hematologist. And if you see right here, you can see someone with steroid refractory hemolytic anemia. The first step is going to splenectomy now. And that is the reason. The presumption is that you have an operation which has a pretty low morbidity and mortality. Oftentimes, laparoscopically, it's a short hospital stay. Um, it's actually preferable to start with splenectomy. And this is something that's really happened over the past decade because early on we see a lot of the failures. And then you move on to steroids, rituximab. And there's some question as to whether or not, just like an ITP, there's some question as to whether some of these medications work better after splenectomy. So thrombocytopenia, so we went anemia with thrombocytopenia, and there's ITP, which is clearly the most common referral for splenectomy. For me, there's acute ITP, which is self-limited, and you only surgical intervention for intracranial bleeding. Now, the interesting thing about ITP is, for whatever reason, the risks of intracranial bleeding is much lower than the average person who has without ITP with thrombocytopenia. Um, so the issue is no longer if someone has a platelet count of say 7,000, there's no reason that they're going to have to be admitted to the hospital. Rather, the treatment is elective splenectomy, and I'm talking about the chronic patients, the acute patients. You just support them. Chronic AP is the vast majority of cases. About 35% of all my splenectomies are for ITP. It used to be much higher, closer to probably 45%, but I'm seeing more and more indications for this. Idiopathic versus secondary. Again, sometimes people are sent to me for ITP, and in the end, they have a diagnosis which may be an underlying lymphoma. Um, Fourth decade of life, women more than men, increased menstrual bleeding, petechiae, ecchymosis, minor surgery, shaving bleeding, spontaneous bleeding not as common, nosebleeds. And then there's an occasional person who's noticed some of the stuff but didn't think much about it. Then they get routine blood work and their platelet count is very low. Um, as Casnell said, and this medical student in 1916 says that it is important. Um, the spleen is important in the role of ITP. It could be a matter of it's probably IgG antibody to the platelet antigen. It could be platelet destruction because of the large number of platelets which are in the spleen at one time, which can be as much as 30%. So make the diagnosis of ITP. It's a platelet count of less than 100,000. Typically, it's not even noticed until less than 50,000, and oftentimes it's even lower than that. The frequency of death with a platelet count of less than 30,000 is 1.6 to 3.9% per year. So this is not a benign condition. A bone marrow biopsy would show increased megakaryocytes, but as we're going to talk about in a second, it really isn't indicated. ITP becomes a diagnosis of exclusion. The spleens are usually smaller than normal, or at least normal size. They should not have neutropenia or anemia because if they have pancytopenia or bicytopenia, the chances are that probably they have another process going on. Anemia related to chronic blood loss, again, you'd ask them about GI bleeding, for example. And this is a paper which is over 20 years old, but it's still important. This is from the Annals in Internal Medicine, and ITP really is a diagnosis of exclusion, history, exam, blood count, peripheral smear. If there's nothing else, there's really not a reason to do any further studies, liver spleen scans or bone marrow biopsies. You rule out everything else, and you can make your diagnosis. And for the most part, they're absolutely correct. So this talks about this is what I thought was interesting in comparison to the paper from 2010. The principal therapeutic options: corticoids, intravenous immunoglobulin, IVIG, Winrow. This is old. I mean, we don't use Winrows much. There's rituximab. There's Nplate. Splenectomy here was considered the kind of the last step. Now, as you know, it's really considered the first step. No reason to transfuse these patients because the patient will be admitted to the hospital. They transfuse them. They'll get them from 3,000 to 17,000, and within 24 hours, it's back down to 3,000. Just with hemolytic anemia, high dose corticosteroids are the first line of treatment. Just like with hemolytic anemia, 75% will have normalization of their counts, but with weaning, you have a sustained remission rate, which is very low. And um, these patients will be back on their steroids, and that's the point that they're usually referred to us as surgeons. Medical management we talked about is IVIG, where the FC receptors on the macrophages are saturated. Winrow isn't used as much at all. It had been done previously as the antibody blockading the receptors, but is less expensive than IVIG. But I just don't see it being utilized at all anymore. Rituximab can be used for a lot of indications. Um, Monoclonal antibody against these antigens. You can see that it says only sustained response for at least 30 years, but I will tell you that I think this number is changing as we have more and more experience with it. I have seen, there's no question I've seen a decrease in the amount of patients referred to me for splenectomy in the past, say 5 years. And I think that's because of other medical management. And if it will work, some people will still feel that surgery should be the last step. Nplate is also new, um, increasing pathways to increase production. Again, is rituximab is Nplate, are they better after splenectomy? And most of the people that the hematologists I work with here feel that they should be used after splenectomy. They think there's some thought that it may be more effective. So this is a paper from Dr. George in Blood, and really what this is important. There are millions of studies out there, millions and millions, but very many studies out there looking at what are the factors which may improve the potential for cure with splenectomy. So this looked at 135 case series with more than 15 patients. And what they found was about a 66% response of in adult patients. But they looked at age. They looked at sex. They looked at past history. They looked at response to steroids. They looked at so many things. None of the 12 characteristics reported as consistently predicting response did predict a response. Mortality was low. Complications were higher with open. So all the risk of the surgery is important. Splenectomy provides a high frequency of durable responses. So 66%. So this is what I will tell my patients. And I, again, got this from my hematology mentors who really pretty much say that 2/3 of all patients will respond to ITP. Will respond to splenectomy for ITP, and of those other 1/3, a lot of them a good percentage will get them into a higher range. So, of course, being a surgeon, we have to say, well, we probably know better. This is a paper that Luciano Testaldi, one of our research fellows, worked on, and it was just actually recently published in surgical endoscopy. So we looked at all of our ITP patients, and we said, well, we're going to find something different. And 109 patients underwent lap splenectomy. This was some time ago, and we had the complete responders, the responders, and non-responders. And a complete responder, their platelet count went to be above 100,000. A responder, maybe the count was between 30 and 100, or double what had been preoperatively. Our morbidity was related to DVTs, portal vein thrombosis. We did have one bleed, no mortalities. And so initially, we had a 91% response essentially. So 91% of the patients went up to above 100,000 platelet count. Only 10 didn't really respond. And a median, 5-year follow-up, 25 patients did relapse. So what you found is the responders, 30 to 100,000 or double, or the complete responders above 100, 68%. And the only thing we found is they responded well to splenectomy in the short term. That was usually a very good sign. But again, 2/3 of the patients are going to respond to splenectomy. I had to look into that. I thought, well, what about the patients who don't respond? And this is a patient from Dr. McMillan. And what they did is they looked at these patients in whom splenectomy failed for ITP, and they found that many of them actually stabilized. And of those, 51 were in remission. And I mean, 51 who were treated remained in remission, but 24 continued with their treatment. And the median time to remission after splenectomy failure. So some of these patients, a matter of almost 4 years later, some patients' platelet counts will go up very quickly and stay up. Some will go very high and then come down. Some people will start low, 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 and get higher and higher and higher. The bottom line is 32 patients died. But what's important, I think, of this is 17 patients or 15, 16% died of their ITP, either bleeding in 11 patients, or therapy complications in sick. So again, IDP is not a benign disease, and indeed, there's a subpopulation of these patients who have severe resistant disease, which you experience significant morbidity and mortality. Again, when I went over was looking through my database in preparation for this talk, we did find it was not, maybe three people who had intracranial bleeds. We had people who were GI bleeding that they just couldn't control, and they were, they didn't want to operate on them because they couldn't get their platelet count high enough. So this is a significant disease. Again, venting the spleen, you can find many slides on Google. I'm just venting my spleen over, you're mistaking it for my gallbladder. I want to talk about TTP for a second, only because it's kind of an area where there's been some change and increased consideration of splenectomy. But in reality, it's far less common than ITP, and it's got the classic pentad of thrombocytopenia purpura, neurologic symptoms, renal failure, microscopic hemolytic anemia, and fever. Is this autoimmune response to the endothelial cell antigen in small vessels? The treatment has always been plasmapheresis and fresh frozen plasma, as well as medical management with increasing options for medical management. However, comma, I don't want. However, I think that it's become common to give consideration to patients who really have resistant TTP, who are they fail treatment, they relapse, and most long-term survivors of TTP have undergone splenectomy. The mechanism is unclear, but again, the presumption is the spleen plays a major role. This is a patient from Dr. Zold, and this is from 2001, and they looked at 8 patients. You don't have a ton of patients to look at, but you found that 7 were in remission after splenectomy. Again, as we get better and better with laparoscopic splenectomy and the decreasing potential risks, I think that increases the popularity of at least considering splenectomy for conditions in the past which were never considered to be surgical candidates. So I said, let me look back, because that was 2001. So I looked another 9 years later, and this looked at 2 patient populations. So it was 87 patients in 18 studies of relapsing TTP and 74 patients in 15 studies with refractory. So you can still see there's a significant morbidity, mortality, usually not related to the thrombocytopenia. But you can see that 17% of the patients who had relapsed and 8% of the patients who did non-responders did not make. There's no improvement, but a significant proportion of these patients did have at least decreasing episodes, decreasing need for plasmapheresis, and sometimes no further treatment at all. So it's definitely something we need in our armamentarium for such patients. I give consideration to Felty syndrome only because it's neutropenia. I've seen it once. Splenomegaly, neutropenia in patients with rheumatoid arthritis, recurrent infections, and chronic leg ulcers. Splenectomy is a treatment of choice. Very uncommon, but we talked about anemia, we talked about thrombocytopenia, and now we talk about neutropenia. I just want to give some time to that. Awkward Yeti, another spleen paper cartoon. And you can see that this is the spleen, which is getting larger and larger because of mono. Obviously, mono is one of the most common reasons for an enlarged spleen. In younger patients, there's almost never an indication for splenectomy unless there's a splenic rupture. So you can see this, but this is going to take us to hypersplenism for the splenic disorders. These are the people who are going to have those big spleens. And you see there's some neoplastic disorders. I've seen several patients with hairy cell leukemia. Most of the patients who have CLL or CML, usually they could have that disease, and many of these maybe have transformed. Non-Hodgkin's lymphoma is going to be most common diagnosis. We're going to see the hemopoietic disorders, myelodysplasia. Some of the physicians I work with here, we see a lot of patients with MDS, myelodysplastic syndrome. We'll talk about that a little bit. Sarcoidosis we see not with a lot of frequency at all. Obviously, splenic vein thrombosis and cirrhosis. Now, you see right here, it says only with JMH's approval. The man who hired me, one of my mentors, J. Michael Henderson, was an expert in portal hypertension, and he's down south now, but I would never touch a patient with cirrhosis with splenomegaly unless he felt that it's a reasonable consideration, really because of the concerns for complications and bleeding and portal hypertension. And quite frankly, it's not going to fix the underlying disease. There are several occasions with low MELD scores, but whenever I see a patient with cirrhosis said to me, I still hear Dr. Henderson's voice beside me saying, be very careful. How I diagnose and treat splenic lymphomas. This is from Dr. Ionito and Dr. Tripotto in Blood, 2011. And what you can see right here, again, the usual things. We talk about the history, peripheral blood, bone marrow biopsy. Again, these are people you're concerned about a splenic lymphoma. That does not mean they have splenic lymphoma, but again, you take all the data. If you have a diagnosis, you're done. If you don't have a diagnosis, it's a diagnostic splenectomy. If you have a diagnosis of B-cell lymphoma, diagnostic splenectomy for high-grade lymphoma or a mantle cell, obviously, but more important, high-grade lymphoma or transformation. And again, when I look at my numbers, the patients I've seen, I'm surprised how many people had kind of low-grade hematologic malignancies, CLL, who the biggest concern, or if you have myelodysplasia, and they can move on to sarcoma, or the patients who have CLL can move, they can transform. So that's an important consideration. Now, the most important famous splenic patient to me is the late and great Dr. Lawrence, Dr. Larry Levy. I was very lucky to spend many years operating right next door to him at a outpatient surgery center. Um, he was really one of the first breast surgeons in Cleveland, and I'm sure probably nationally. And whenever patients were down about their diagnosis, he would lift up his shirt and show them his big splenectomy scar, performed by Dr. Ponsky, of course. In the old days, but previously, staging laparotomy were the standard of care for lymphoma. So you would actually remove the spleen to look for disease. You don't do that anymore unless you have difficulty making the diagnosis. You don't do it in and of itself. But I always remember that, and I can tell you, patients have told me when they saw Dr. Levy and they were kind of down about their diagnosis, he really and truly did this. That's the kind of wonderful man he was, and that's why he's the most famous splenectomy patient of all time. So when you do have some of these spleens which are large, and I'm talking about these concerns about lymphoma. The patient who I showed the first slide, he had splenic marginal zone lymphoma. This is from my colleague Stacy Bretthauer, who's immediate past president of the ASMBS, the Bariatric Metabolic Surgery, and just a wonderful surgeon. But when he was a fellow in 2006, we looked at our splenectomy for splenomegaly, and obviously a higher conversion rate, higher complication rate. You can see 3 reoperations for bleeding, portal vein thrombosis, abscess. We were able to confirm the diagnosis. So these are people who splenomegaly, who the concern for, they were worried that there was an underlying splenic lymphoma. And you can see that surprisingly, some of these were negative for malignant disease, and they simply had an enlarged spleen with pancytopenia. And I'm interested enough, when I look back at these patients over time, a lot of them were ultimately diagnosed with an underlying process. Mass symptoms were also a significant consideration in these patient population. We'll talk about that when we talk about myelodysplasia. Almost half of the patients with cytopenias resolved. Diagnoses were made, and most of this, every patient who has mass symptoms, so left upper quadrant pain, early satiety, these all resolved with a splenectomy. And when I say splenomegaly, I talk about these are people who are large. These are spleens which are larger than 1 kilogram, and this was just looking at the laparoscopic patients. So it's a very important diagnostic and therapeutic tool. Sarcoidosis is another thing that we don't see as regularly, but some of the largest spleens that I've ever seen have sarcoidosis. There'll be some masses in the spleen, and so what you worry about is there an underlying process going on. Splenectomy is helpful because many people have symptoms. It doesn't really change the disease process at all. Myelofibrosis is something that we um, we see a lot here at the Cleveland Clinic. It's fibrotic replacement of the bone marrow with extramedullary hematopoiesis and massive splenomegaly. Um, the reason that most people are referred to me with myelodysplasia is because of symptoms or the need for transfusion. Um, the thought is maybe you can decrease the need for transfusion rate in these patients with splenectomy, but that really has not been the case. Some patients have responded very well, but many patients don't, and so you're not really going to make a big difference in these patients. Life-threatening thrombocytopenia, it's the same thing. Some people will respond at least a little bit because you have this element of hypersplenism, and 30% of the platelets will be in a large spleen. But really, it's the symptoms of splenomegaly. And some of these people are absolutely miserable. They come in, they have temporal wasting. They just have a significant pain from the size of the spleen. So really, that's the most reasonable reason to consider splenectomy is more for the symptoms. And you can look at this paper from Dr. Teferi in Blood again in 2000, and they took 223 patients with myelofibrosis, underwent splenectomy. Same things that I see as people were transfusion-dependent anemia, symptomatic splenomegaly, and pancytopenia. Morbidity is pretty high. Mortality is higher than you like it to be. The only thing that really improves with splenectomy in these patients are early satiety and left upper quadrant pain. Two-thirds of these patients will have improvement, and some of these patients are so miserable that that's all they want. Unfortunately, only not even a quarter of these patients got off of the transfusions. Maybe as opposed to weekly, it becomes biweekly, and thrombocytopenia does not respond well to this. So it's really the benefits are not prolonged, but they may be for quality of life issues. Again, these are usually large spleens, so they're going to get an open splenectomy as well. So that has to be taken into consideration. Again, spleen gets no respect. We need to remove your spleen because it might not be doing whatever it is the spleen does. So let's talk about primary neoplasm cysts of the spleen. Um, this is something that we don't see. I get a lot of referrals for quote cysts or mass of the spleen, but it's very unusual that we end up operating these patients with no, that's true. But what I would say is you have epidermoid cysts of the spleen, vascular hematomas, post-traumatic cysts. So most neoplasm spleen are post-traumatic cysts. We'll talk about this a little. I've seen a few of these. The first one I ever saw was a kid who was he was like in high school. He was a goalie in soccer, and he was just having this upper abdominal pain, and they saw this big symptomatic cyst. Well, he remembers at one point he'd been kicked in the abdomen during a match, maybe 6 months previously. Inflammatory pyogenic abscess, fungal microcyst, pancreatic pseudocyst. Now, I would say I'm not going to talk about uh, the cysts, which we'll see the cysts we see in the Middle East around the sheep and all that, because we don't see that here. Although obviously that's important. And neoplastic cavernous hemangiomas, lymphangioma, lymphoma, and metastases. We've done a few of these for metastatic disease. These are just a couple of pictures you can see. They can be something as you see on the CT scan, something funny like this. You can see these small masses, but you can see why. For example, you look at the picture of sarca. This is lymphoma. This is lymphoma. We obviously had to convert to open on this guy. How you can see that sarcoid could become a concern when you see this on the CT scan. This is Vic Adeluri was a resident. He's now in California, colorectal surgeon. This is a presentation to SAGES in 2010, and we looked at splenic masses. So this is from 2009. My numbers have increased significantly since then. 54 lap, 7-hand assist, 13 converted to open. Again, mainly reason to open for size or for bleeding. We actually had two misfires in the staplers, and that was in the early days of some of the staplers. We don't have those issues, knock wood. any further. Obviously, the mean splenic weight was 624 grams, so these are bigger spleens than normal. 56 were malignant, of which most of them were non-Hodgkin's lymphoma. We had metastatic disease in several patients. We had Hodgkin's in 2 patients, multiple myeloma in 1 patient. 18 were benign with meningioma. I don't just operate on every patient who has a mass. I think I'll go down to radiology. I'll go with these films. I'll make sure that everyone else is in agreement that this is concerning for an underlying malignant process. But I would say a huge percentage of the patients referred to me for splenic masses are sent away because there's no reason to do anything. It can be diagnosed and curative. This is, sometimes you got to shoehorn a great cartoon into your talk. My favorite group, I'm still living as if it's 1983. My favorite group is The Cure, and you can see here's the 23rd annual race for The Cure. So these splenectomies can be diagnostic to help make the diagnosis of what's going on in the spleen, and they can be curative. Some patients, after you do the splenectomy, this may be splenic based, and may be no further treatment, or quite frankly, that it's benign. So this is a picture of that the young man with the splenic cyst, very symptomatic, and most of the patients who I've seen for splenic cysts has been seen elsewhere, and splenectomy is recommended. Usually what we do is we just, again, we're not including the hydatid cysts, which we talked about. You open it up. There's a lot of kind of old blood in there, and you can actually see here that this is the capsule, which we usually excise, but this is all going to get back to normal splenic tissue. We just leave it alone, and these patients have all gotten better. So now we're talking about why we're doing what the spleen does, what are the underlying diseases, how do they respond? Let's talk about how to take the spleen out. And this is really a big paper from Archives and Surgeries, 1999, by Dr. Parton and his partners. And what they found was, compared to open splenectomy, lateral approach, and he was one of the first proponents of the lateral approach, Dr. Park. Laparoscopic takes longer to perform, but results less blood loss, shorter postoperative stay, fewer complications. And so really the cost is decreased. And I don't think at this point there's anyone else who would argue that we should be doing open splenectomies for most patients. I tend to find in the smaller spleens that I think laparoscopic is maybe not quicker, but much easier. The visualization is improved, particularly in some of these small spleens are way up in the left upper quadrant. So I went to another paper from 2003, and this was 2,900 patients from published series. And what they found is, again, there's a significant difference in time, the surgical time. But I do think that with experience, this number is kind of coming closer together. Hospital stay was shorter. Our average hospital stay is 2 days. I do a lot of these on Fridays, and I would say a significant majority, of the patients go home in 2 days. Total complication rate was lower. It's still relatively high, but that's including all things. It just seems like a very high number. But obviously, I'm not surprised that a quarter of the patients with open splenectomy will have more of an issue. But you call the complications is hemorrhagic, is bleeding. And when you're open, you have bleeding. You can sew it. With you're doing it laparoscopically, sometimes you are going to have to open it, and that makes it a significant complication. But most of the wound care issues and the pulmonary issues are not much of an issue at all with the patients undergoing laparoscopic splenectomy. So his conclusion would, again, it should be I think it should probably be the treatment of choice. Now, not in everybody. I still do open, and we're going to talk about some of the other approaches as well. And of course, everybody does a NISQIP paper here, but this is a nice paper from recently. And what they found, again, this was a lot of patients, length of stay, 3 versus 6 days, lower serious and overall morbidity. And the mortality, it was higher open, but actually when they did regression analysis, they found that the mortality was not necessarily associated, was not higher necessarily with the patients who had undergone open splenectomy. But there's no question that the rate of complications is much higher with the open approach. So obviously, when technically possible, the laparoscopic approach is preferred. And I would almost go so far as to say that even if I just don't think that there's anyone who would disagree with this. I think it's beating a dead horse, but I think you have more than enough. Reason to do this laparoscopically. But I would also say that, there are people for whatever reason, prior abdominal surgery. I've had some patients who've had prior gastric surgery, prior, sigmoid colectomy, patients who can't tolerate laparoscopy. There's nothing wrong with the open approach, and I would never fault anyone for doing it. These are size considerations, and I can show you this is the original patient with the splenic marginal zone lymphoma I showed at the beginning, and you can see that there's just, this is just crazy. I don't think I'll ever see a spleen like this. The next, this was a big, again, almost 15-pound spleen. And the funny thing about this patient is I happened to see him because he was getting his chemotherapy, and I ran into him about a year later, and he was a different person. I mean, temporal waist was gone. He was back to being a chubby guy. He was just happy as a clam, and he had completed his treatment and looked like a different person. So when you look at these pictures here, I don't know, it became a tradition to take pictures of these spleens. This is Pete Kramerman, who is this was a long time ago, who was a plastic surgeon in North Carolina. And this is Matt Crow, who is my partner at Cleveland Clinic Abu Dhabi. And this was a big spleen, but it wasn't the biggest spleen, obviously. This is Mike Liu, a colorectal surgeon in Ohio. We did once, I was asked to do a accessory splenectomy for one with persistent ITP. I didn't think it would make a difference, and it obviously didn't because it only weighed, 40 grams. Again, the largest one was the 14 and a third pounds. So when you're talking about all these really big spleens, you know, what is it compared to the open approach? We talked about that, but what are the potential risks? This is from Dr. Fielding from Annals of Surgery in 2003. Lap splenic is an alternative open splenectomy. I think in 2003 it was looked at as controversial. I think now it's more of an issue of what are you comfortable with? How big is the patient? If the patient has a pretty big spleen as a small person, you're not going to have a lot of ability to optimize your exposure. If the patient is a pretty big guy or woman, you may have a better chance. Now, I would, again, for the sake of this discussion, we're talking about massive splenomegaly being more than 1 kilogram. And we looked at mortality, morbidity, adjusting for age, weight, pre and post-op counts, OR time, and everything. 1/4 of massive splenomegaly was found in these patients. What they looked at, splenic range was from 1,000 to 4,750 grams. So the median was 2.5 kilograms. What they found was obviously longer OR time, higher conversion rate, increased morbidity, higher operative stay. Splenic weight was the most powerful predictor of morbidity, and I don't think anyone would necessarily argue with that. But I think that that's more of an issue with the approach. And what I mean by that is it's feasible, but is always right. Is it always right to try to do these laparoscopically? I will tell you that a lot of the patients who I have laparoscopic conversion to open, not patients who, for example, previously I converted for staple misfire, for bleeding, which I can't control, for, I'm worried about, whatever. A lot of these patients, I will start off laparoscopically only to try to do as much dissection as I possibly can to try to get, free up the lateral attachments, the splenorenal ligament, try to free up the splenophrenic attachments, maybe even try to get medial and try to take down the short gastric vessels, knowing that I'm going to have to open. But as much as I can do laparoscopically, I will do laparoscopically, and then I'll the patient's been secured, I'll rotate them airplane as flat as they can be, and I'll just do a midline incision, and most of the work has been done for me. So I think, yes, it is feasible. Does it mean it's right? Not necessarily. And again, no one is going to be faulted for doing, I push the envelope now because I've done more, but I think early on I would have just mostly open. But I can see some of these patients, and in 2 seconds I'll be like, we're going to do you open. I wouldn't even consider it. So I think that that's one of the issues with splenomegaly. This again is a picture of that gigantic spleen, which is bigger than a baby. So looking at the numbers, I've done, you can see that 17 of the 391 splenectomies I've done, so almost 1 out of 5 were done for spleens larger than 1 kilogram. Unlike spleens less than 1 kilogram, where 78% of them are done lap, only about 21% are done lap. Lap to open, 18% And I would say to you that, again, some of these are ones that I've tried to do as much as I can lap with the understanding that I'm going to convert to open. Hand assist, we're going to talk about. I don't do that anymore. And then most of them are open. So 56 are open versus the 14%. When you look at the complication rate, it's definitely higher. I did have one man go into DIC and we just couldn't control, and he did die on the table, as opposed to 0.8% post-operative bleeds. It's 4%. And interestingly enough, we had two pancreatic leaks, which you think we would be able to see the tail of the pancreas a little bit better using the open approach. So that leads me to the thought, or the topic of hand assist. And I put this paper in here because it's a who's who of important people in my career. Mike Rosen is my partner, my friend. These are the days when every paper he wrote wasn't about hernias. He's my section head. Fred Brody at GW, I was his fellow, who really taught me how to do this operation. Matt Walsh is my chairman, and Jeff Ponsky, as we talked about, is the reason I'm talking. He's been a mentor and a supporter, and they wrote this paper, and this is when Rosen was a research fellow in 2002, and they talked about doing HALS, hand-assisted laparoscopic splenectomy. They thought that it's efficient for spleens which are greater than 22 centimeters pre-op, or presumed to be greater than 700 grams post-op. And I will tell you, this is a tale of two spleens. For whatever reason, this is my hand holding the spleen for the resident. Just when we're done, we can see that this is the staple line in the foreground. This was a big spleen. It doesn't do it justice. But this woman, the residents and I, we struggled for probably about 4 hours to get the spleen out. It was a woman who was in her 70s. She ultimately was diagnosed with non-Hodgkin's lymphoma. We really struggled. We had the hand assist port. We did this operation, and she did very well. Probably in the hospital for about 3 days. No further treatments. Well, the following week, it was just so frustrating to do this hand assist that I actually said, let's just do it open. So we do the case open. Same thing. A woman in her mid-70s, large spleen. Both the same size. The incision had to be big enough that we could get the spleen out. But in the end, she went home in 3 days. She didn't even know if she had, she didn't know the difference was lap or open. She didn't care. And so my feeling is I don't really do hand assist. There's absolutely nothing wrong with hand assist, but it's almost like it's either lap or open. If it's in between, I will do lap. Start off lap to free up as much as I can and convert to open. I don't think, sometimes you'll see that the attachments are so attenuated that it's very easy to rotate the spleen, and you can optimize your exposure. So I'll start off lap if I think there's a chance. With time and experience, I'm much more comfortable doing spleens, larger spleens. So 700 grams doesn't really phase me, although I know I may have to open. So I'm not really into that. So I'll take this moment and go against that paper done by 4 of my friends and colleagues. Helen Hennigan is in Ireland. She was a fellow, an MIS fellow a few years ago, and we did look at obesity, and it really did make a big difference. Again, I think that the difference is particularly in men of more visceral fat. Some of these heavy patients, you have to get off the steroids because they just can't even lose weight because of that. Their blood sugar gets out of control, and it was longer OR time, but there was no difference in the rates of morbidity, hospital stay, or even blood loss. After you've taken the spleen out, just I got to touch on this, is that you're going to see Jolly bodies, Heinz bodies, Pappenheimer bodies, target cells, spur cells, platelets. You have a transient lymphocytosis, thrombocytosis, which comes down. I will say that some of these people with very large spleens, I follow them closely because if their platelet count goes above 1 million, we put them on aspirin. We don't do it in advance, but we will see what their platelet count does post-operatively, just to minimize the risk for particularly portal vein thrombosis, transient leukocytosis, lymphocytosis, and persistent monocytosis. And just to show a couple pictures here, again, you can see Jolly bodies and Heinz bodies with the bite cells that you'll see after splenectomy. We did talk about that in the after people realized that hemolytic anemia could be resolved with splenectomy. They had a couple family members die of sepsis, And the seminal article was in 1952, and you can look it up in the Annals of Surgery. Um, Risk is inversely related to age, so that's why they hold off on splenectomy as long as they can, the pediatric surgeons. Increased risk of sepsis in adults. It can happen within 80% happen within 2 years, so it's not like it's going to happen post-op. Sometimes the residents get crazy if the patient has a low-grade temperature post-op. I'm more worried to get a post-operative fever, well out. Um, it's related to the underlying conditions. The mortality can be significant and associated with the encapsulated organisms. Is it filtration? Is it immunodeficiency? We talked about the opsonins. It's really not completely well understood, but this is a paper from Dr. Cuscieri from a long time ago, but it still shows they looked at 12,500 patients, and 4% of patients less than 16 would develop overwhelming post-splenectomy infection or sepsis. Adults were much lower. Um, um, and they do have a different presentation, more of a meningitis with children, whereas a septicemic type illness with adults. Looking back on the splenectomy patients, it's rare, but we've had several patients who have developed these infections. We'll talk about this a little bit more. Pneumonia, S pneumonia, strep pneumonia, H influenza, and meningitis. Um, I think that this is what we're most concerned about with these patients is the overwhelming post-splenectomy sepsis. And these are the immunizations. Dr. Ream, Susan Ream in infectious disease has helped us this is her recommendation, and we follow it obviously, where you can see within a couple weeks of surgery, they get their Prevnar, they'll get the Hib vaccine and the meningococcus. 8 weeks afterwards, they'll get a repeat. They'll actually get a pneumovax and a meningococcal. Yearly influenza. 5 years after surgery, they should receive their pneumovax once again, and all vaccines should be up to date. This is something that we give to the patients. Number one, so that they have it if they're going to get their injections closer to home, immunizations, or if we will do that for them. But it also will say several things, not the least of which is a prescription for antibiotics. So we tell patients, you can say Augmentin or Levaquin, really for any symptoms of infection or sepsis. What I will tell these patients is, you can be sick, you could be around sick kids, but anytime you have an illness characterized by a high fever, I want you to get immediate medical attention. You can call me. You can call your primary care physician. This will be on record. But this is what we do for our preoperative immunizations, and this is pretty much the most up-to-date recommendations from infectious disease. So we're kind of slowing things down, kind of wrapping things up. My experience, 306 laparoscopic cases, 27 lap to open. I'll just move this. 52 open, 6 hand assist. I don't do the hand assist anymore, as we talked about. 54% male. Main diagnosis ITP. I am seeing more and more. So this used to be a much higher level was ITP. More and more splenomegaly. More and more people referred to me for the large spleen, of which a lot of them do ultimately end up having some pathology, usually a non-Hodgkin's lymphoma, average age, average size, and we talked about the splenic spleen size. So this is the patient positioning. So this is how I end up doing it. There's a things that this adds at least 30 to 45 minutes to the procedure. This is a case we did a couple weeks ago. And you can see we want to make sure that the anterior superior iliac spine is right at the break of the bed, and you can't see this well because you really want to open this up. This is a beanbag hold in place, double arm board, axillary rolled, taped in like crazy because, again, the benefits of this position is that you can rotate them and use gravity to help rotate the spleen medial lateral to however you want this. Obviously, I always put a Foley catheter, and I usually keep that overnight. The first sign of intra-abdominal bleeding is, in my opinion and in my experience, is not hypotension, it's not tachycardia, it's just suddenly decreased urine output. So I watch the urine output very closely for the first day. I haven't drawn it on here, but this is the costal margin, let's say here. And I usually I start off with 4 ports. I use the endopat trocar, an optical trocar, and I'll usually mark it out. I'll figure out one. I use 4 ports, one here, here, and here. Now, sometimes if it's a large spleen, I'm going to come way medial here because I'm going to have to get down below the spleen. Sometimes I'll come farther. Sometimes I'll set up so I can have a 5th port if I want it. But we use an endopad trocar, and usually I put it in the epigastrium. That's my first port. And you can see right here, this is the costal margin. This is an old picture, but you see how these are usually about a palm's breadth apart. Carefully assess for accessory spleens, and suddenly you found that this was 1 in 10 people have an extra spleen. Right next to Edgar Allan Poe, and the fact that St. Lawrence Island, Alaska, can see Russia 37 miles away on a clear day. So we talked about this before. The first thing I end up usually taking down is the splenocollac ligament. So I get my fourth port over here. This is usually avascular, but it's important to stay well away from the spleen. You don't want to get lost just enough to get your port in here. Take this down to your fourth port. This, looking downwards, this is the splenophrenac. And once you incise this, you actually see Gerota's fascia underneath it. So some people start medially. I always start laterally, and I keep working my way upwards here. So again, the splenorenal ligament, get into it. You can see the fat here. This is a harmonic scalpel. A lot of ways you can do it, but this is kind of the best picture of all of them. Two hands to rotate medially, and you're going to keep coming up here. And I let come all the way upwards until I didn't put these well, but I come all the way up here until I can see the stomach, all the way around here. An important aspect of this operation is to take down the superior connections, so you can rotate the spleen medial and lateral. Inferiorly, I usually use the harmonic. I feel comfortable with that. There's a lot of other devices you can use. You can use staples as well. There's always going to be an inferior pull vessel, ultrasonic dissector. So I go lateral all the way to see the stomach. Inferior, I want to take down as much of these attachments as I can. Sometimes they can be very thick because of the thick omentum, but it's nice to really optimize your exposure. Then this allows you to really lift up. I usually take an inline lift up on the stomach, enter the lesser sac, and just start taking down all of these short gastric vessels here. And you can see you have nice exposure. But again, you really want to free the superior pull-up as well. What I often do is I take a soft bowel dissector, put it way past the I put it posteriorly, and then I drape the spleen over it, and you have a window of which to place your staple, and you can see it right here. The stomach is well away, the tail of the pancreas is well away, but you got to watch for some of that kind of stuff, and you can use a harmonic, you could actually use a hook just to take down this peritoneum. And then we staple the hilum. Now, the only difference in how I use this now is this is an endo-GAA. I actually use seam guard reinforcement. I found that there was less bleeding from along the staple line. I feel like I've done my job if it takes one or at the most two firings of the stapler to get across this, and then we lift the spleen up. So it should be an upside down turtle, put it in the bag, and retrieve the spleen, and this is what it should look like. And it's amazing how many patients really appreciate a picture of their spleen. This is a good example of a lot of things. This is the example of the spleen that we did about 2 weeks ago. The man had a huge left upper quadrant mass, as I said, which was related to lymphoma. The adhesions were horrible, but his PET scan was still lighting up. So the concern was, does he have persistent disease? So again, we're looking for diagnostic, potentially even therapeutic, after he'd been treated with his chemotherapy. It was a very difficult case. It was a normal size spleen. The attachments were severe. It took us, 4 to 5 hours to do this. I always thought I was making progress. I didn't think there's a reason to open. And in the end, ultimately, this was benign. And that was worth it for this patient and for me in the end. So I just want to show a video right here. And of course, this is the endopad trocar. Again, I put this into the epigastrium. This is an old video because it's such a small, the old metallic trocars and such. That's the harmonic. This isn't much of the splenocollac ligament, but of course I would never have a difficult procedure. This was a pretty straightforward case. So we'll take this down, staying away from where the colon is, getting down laterally. So again, I usually use two hands to retract the spleen. There should be two retracting. And I think the one thing that you become more comfortable with over time is realizing you can really push pretty hard on the spleen to optimize your exposure. And we start marching this upwards here. Again, this is an ITP spleen on a very thin woman. It's pretty old. It's kind of an old video, but I don't really video a lot of my cases. Coming along Gerota's fascia right here, you can see we're just going to continue marching. So I go lateral. Now I know plenty of people will go medial first. There's not, and they'll keep these attachments intact. I just find that when you're doing a case like this, it's really nice to take down all of these attachments, keep working your way upwards. And what you're going to want to see is you're going to want to see the stomach. You got to be careful for the diaphragm. You got to be careful for the the phrenic vein more medially. You're going to find the stomach, and with a heavier person, it's very easy to get into the and to get very close to that stomach. So be very careful for that. But just keep working. And I just saw a little movement. You'll see in a second that when you push down, you'll see here's the stomach back here. So now we rotate the spleen. Yeah, it's a chip shot. I wouldn't give you a difficult video. Soft bow, an inline grasper, whatever you want. But I feel that works well. You can get into this. You can get into this lesser sac. The resin does this weird move, which makes me crazy. He just kind of pushes on here. I don't know why. Just get in there. And what you can do is you can march along here and you can take down. It's always funny when I can watch a video and I know exactly who the resident who's doing this. All right, so we're coming along here and we're going to open things up just so we have optimal exposure of the splenochylum. And I think that this is a place where I know now to spend much more time to really start working on freeing up as much as I possibly can. You can see the vessels down in here. But really, if you can't rotate the spleen medial and laterally, then you're going to have difficulty getting your stapler across. And sometimes these attachments here can be very difficult because the stomach can be completely attached to the spleen. Sometimes you have to switch over to sharp scissors. Again, just being careful. I've had 2 patients in my career who developed holes in their stomach, and I don't know if it was from grasping or it may have been a thermal injury. My guess would be a thermal injury. So this is another point where you have to kind of worry about this. When you move it, when we rotate the spleen laterally, you can see you have some of these attachments. This is what I say, even with a large spleen, and this is what I mean when you have a large spleen and a small person. Look, he's just stabbing that spleen. Oy, oy, oy. You want to rotate it. You want to push this over so you have something to lift up on. But with a small patient, large spleen, sometimes you're not going to get this kind of rotation, and that's really the key. So sometimes you know that you're going to have to convert to open if you can't get optimal visualization. There is the soft bowel back behind there. You can push this up here so this has something to follow along. Then I take one of the 5 ports. The beauty of the 5 camera is that you can just kind of keep moving it around. Then I upsize one of my ports, and this is an echelon, or this is an endo GIA. I do not have. You have to be careful not to grab the instrument back behind you. You fire it. Again, I use seam guard now. And then what we do is we will just take this, free the spleen up. If there's any other attachments, we'll take care of them. Here's your staple. You have you'll see some bleeding here, but by the end, this is stopped. Large spleen bag. I don't use the endo catch because I think that I want something that's a little bit bigger, and I'm more comfortable putting my hand in there to morcellate. You have to make sure that your one incision, you see some bleeding there, you clean this off and I make sure that I'm completely comfortable before I leave the operating room. I have to make sure that when I put my port in, my second knuckle should easily fit into the abdomen, in the fascia, so otherwise you have difficulty morcellating the spleen. There's nothing wrong with making the incision a little bit larger.